Dear students, we at Government Medical College Srinagar Department of Community Medicine have started a series of lectures on maternal and child health. And our faculty members will be taking classes on various topics related to mother and child health. Today, we shall be talking briefly about introduction to maternal and child health problems. At the end of the presentation, we expect that students understand the maternal and child health dyad and the mortality and morbidity in this very important group, that is mother and child health group. If we look at the world population, we call the graph which is representing age as well as the population size as age pyramid. So usually it's a triangular in shape, and with the advancement of age, the base becomes narrower and ultimately the apex is very narrow. Once we look at the base, the most of the populations in the world have wider base because of growing number of children, but in developing countries over the years this has become narrower, and in most developed countries it has become even much narrower with a bulge in the center. And once we look at the age of different genders, we see that most of the cases in the younger age group have bigger size. So once we look among the males, around 13.2% of population comprises between 0 to 15 years among males, while among females it's around 12.4%, and cumulative it's around 25%, which is one fourth of the world population. Once we move to the reproductive age group, that is women in the age group of 15 to 49, we see again around 25% of the world population comprising of women who are in the reproductive age group. So once we put both them together as mother and child dyad or reproductive woman and child dyad, we see that half of the world population comprises of these two important groups. So why do we take mother and child dyad together? Once a woman becomes pregnant, she is harboring a fetus starting from the inception through the 9 months, and once the child is delivered, the child wholly depends on mother's breast milk, especially during the first 6 months of life. And once food is added to the nutrition of the child, supplementation is done, and it continues with the breast milk till 2 to 3 years of life. Then the child grows up, but the attachment of the child with mother continues, especially the physical bonding and emotional attachments. Then this child starts growing, but again it starts, though independently it starts to live, but continues to have a maternal attachment. This child develops into an adolescent and starts developing uh, womanhood process by way of developing primary and secondary sexual characters. And once she become a woman, and she's once she get married and conceives, this process continues in the woman. So this whole process of mother and child continues as a cycle, and we take it as a dyad. We are talking about maternal and child health problems today, and so we will be discussing the maternal health issues and the child health issues. So going to the maternal health problems, we will be discussing about morbidity, especially during pregnancy, and purpurium. Purpurium is the time period which is after delivery up to 6 weeks of delivery. And we will also discuss about mortality. So it will be antepartum, that is before childbirth, intrapartum during the childbirth, and postpartum after the childbirth. And we have seen many things happening during the childbirth are reflected into the postpartum time. Same way, we will be discussing about child health problems, which will be both the morbidity as well as the mortality, and we will be discussing it in various age groups. That is, during intrauterine life, when the child is fetus, then during the birth process, especially because of obstructive nature, then the postnatal, which is divided into neonate, that is first 28 days of life, which is further divided into first 7 days of life, that is called as early neonate, and a later part of the neonatal period is called as late neonate. Then first year of life is very important for the child, and that is an infancy period. And what we have seen, the most of the morbidity and mortality among children occur under 5 age group. So we will be discussing these things. Let's move to the maternal and child health, mortality and morbidity. And to begin with, we will be discussing maternal mortality and morbidity. So, once we look at the maternal mortality, the risk of maternal death has two components. So, number one, if is the woman ready to conceive and to harbor a pregnancy, this is very important. So, once we have seen that young adolescent pregnancies have higher chances of abortions and mortality because of development is not up to that level that they will harbor a full-fledged pregnancy, or they may not be physically and mentally ready to continue with the pregnancy. And sometimes the couple doesn't want to have a child, so they have failure of contraception, or they don't want to continue the child further because of some morbidity in the developing fetus. So this is one of the risks that lead to maternal death. And the main issue of maternal mortality is from the obstetric risk. That is the risk she has once she becomes pregnant. We have seen women in their reproductive age group dying more during pregnancy and childbirth and in the puerperium than dying in the other parts of their reproductive age group. So, what are the underlying causes of maternal death? We will be discussing briefly about the important ones, and the most important one is the obstetric hemorrhage. It is the hemorrhage that occurs during the pregnancy, or during the childbirth, or during the puerperium. And it has been seen that over 27% of all maternal deaths occur because of hemorrhage. And as I said, it could be before the pregnancy, and that time, sorry, during the pregnancy, and that time we call it as antepartum hemorrhage. And it can be because of early pregnancy loss. And many a times it happens that a woman conceives, and she only comes to know once she missed the period, and later after few weeks or months she had a bout of bleeding, and during that time the products of conceptions are expelled from the uterus, and she had aborted. Then only she comes to know about it. And later part of the pregnancy, the hemorrhages during the pregnancy can occur because of abnormal positioning of the placenta, or the early separation of the placenta, which is termed as placenta previa and placenta abruptio, respectively. And but what we have seen, that most of the maternal deaths have occurred because of hemorrhage, and that hemorrhage occurs after the delivery. And three-fourths of all hemorrhages have been reported at the time of delivery and during the time of puerperium. And it's because of abnormal delivery procedure, and many a times it has been seen that the uterus doesn't contract, and there is atonia of the uterus that lead to a massive hemorrhage. And unless an active intervention is taken, a woman can die of hemorrhage. Among the other causes of maternal death is hypertension. If a woman who is already hypertensive continues the pregnancy, she has more chances of having serious complications. But what has been seen, that women who are normotensive become hypertensive during the later part of pregnancy. And if a woman becomes hypertensive after the 20 weeks of gestation, that time it's labeled as pregnancy induced hypertension. And it has two components. If she has hypertension and with proteinuria, that is, the urine has protein component also, then it's labeled as preeclampsia. And once the lady with preeclampsia starts developing convulsions, that time we call it as eclampsia. So a preeclamptic woman with convulsions is labeled as eclampsia. So these are the two major classifications of pregnancy-induced hypertension, and it has been seen mostly among women during their first pregnancy, among women who have underlying other medical causes like obesity or diabetes or some other cardiovascular diseases, or if a woman is already hypertensive at the time of conception. And these conditions are associated with higher mortality because it can cause perinatal mortality, loss of the fetus, or it can cause abruptio placentae, that is early separation of the placenta. And it has been seen that such women who develop pregnancy induced hypertension are at higher risk of developing cardiovascular diseases in later part of life. The third cause of maternal death is pregnancies with abortive outcome. It has been observed that around 8% of all maternal deaths occur because of abortions. Abortions can be either spontaneous, because as I said, she may not be aware that she has conceived and there is bout of hemorrhage and she loses the product of conception. It could be either because of genetic disorder in the developing ovum, and sometimes because of various social reasons, especially among unmarried women or adolescent girls who are not ready for pregnancy. They try to induce the abortion, and though facilities are being made available by the government at various health facilities, even the private hospitals have to provide facilities to such pregnant women, but they try to approach the coax to have induction of their abortion, and because it's been done clandestinely, and that can cause problems in these women, especially they can introduce infection to them that lead to sepsis. They can traumatize the uterus and genitourinary tract also, that can lead to perforation of the uterus, that can lead to frank peritonites, and many a times such women land in hospitals as peritonites with shock. And another major cause of pregnancy with abortion are that instead of normal settling of the ovum in the uterus, it migrates to some abnormal places like fallopian tube, and because of small size of the fallopian tube, the growing uh, ovum and the fetus just burst the fallopian tube, and it causes massive bleeding, and the patient may suddenly collapse and land in shock, and if action are not taken, it may cause death. So these are three major causes of uh, ha- uh, maternal deaths. Other causes other than obstetric hemorrhage, hypertension, pregnancy with abortive outcomes, we have infections in pregnancy, and commonly it's termed as sepsis. And again, around 10 to 11% of all maternal deaths are because of sepsis. It happens because of, as I said, uh, pregnancies are carried out in situations which are aseptic, which are having septic conditions where no aseptic precautions are taken, or in clandestinely those abortion centers, such uh, abortions are carried out, or in situations of home deliveries where sepsis is not taken care of. And most of the time, such women land in sepsis during their perpural time after the delivery, and it can lead to perpural sepsis, and it's a major cause. And some many a times, such women who have genitourinary tract infections also lead to sepsis because of hemogeneous spread, and they can have other causes of perpural sepsis. And even women who have some breast abscess, if it's not taken care, can have a hematogenous spread and can lead to sepsis. So any infection during pregnancy or childbirth and perpurum need to be taken care to prevent any sort of maternal morbidity and maternal mortality. Further causes of maternal death include other obstetric complication, and again around 3% of all maternal deaths have been found because of obstetric labor. Uh, it happens because of the reason that once the pregnant lady has a term pregnancy, the fetus tries to get pushed out through that track through the pelvis, and but there is at times the cephalopelvic disproportion and the head gets stuck and it causes obstructed labor. And also because of abnormal anatomy of the tract, or because of the some genetic disorder among the fetus that can cause obstetric labor. Other unanticipated complications of management of pregnancy could be because of delivery complications, and again, it accounts for 2.8% of all maternal deaths globally. So, in addition to that, we can have non-obstetric complications, especially in women who have some underlying diseases. And it has been seen that over 70% of all uh, such deaths have been attributed as indirect causes, especially in women who have pre-existing medical conditions like tuberculosis, malaria, HIV, AIDS, which are exacerbated in pregnancy. Though we don't see much of HIV/AIDS death, but if we look globally, around 1.6 of all global deaths are attributed to HIV/AIDS infection, and in some of developing countries in the African nation. Continent, like in South Africa, 32% of all deaths there are because of HIV infection. Within that South Africa, we have Swaziland, we have Botswana is nearby, then Lesotho is there. So all these countries have higher proportion of deaths in maternal age group because of HIV/AIDS. So if we look at the CHERG conceptual framework of maternal death, if main complications can occur because of obstetric hemorrhage, hypertension, sepsis, abortion, obstetric labor, which you have discussed, and there could be thromboembolism there. All these things can cause complications, and as we see, maternal death is a major cause, and many times maternal near miss situations occur if some intervention is taken. And with obstetric hemorrhages, women leads can have anemia. Usually 50% of pregnant women already have anemia, and they can have more anemia. With abortion, they can go for incontinence, and again fertility is major risk among them. And though many a times we can have full recovery, but we need to take care of the risk factors which we have, so that we try to reduce the complications which arise because of these risk factors, which could be because of anemia, prolonged labor, obesity, unsafe sexual practices, and HIV infection. After maternal mortality, let's move to the maternal morbidity. We need to reduce this also. So we have discussed about prolonged labor, and it can lead to obstructive labor. If a labor is beyond 12 hours, despite good uterine contraction and good cervical dilatation, it is because of the mechanism reason. As I already said, in obstetric labor, it could be because of cephalopelvic disproportion, abnormal presentation could be there. There's a breach, or there is transverse lie, or there is fetal abnormality or abnormality of the reproductive tract. All these things can cause obstetric labor, and that is again a major um, maternal morbidity. As I said, anemia comprises of around over 50% of all pregnant women are anemic, and we label anemia among pregnancy when the hemoglobin is less than 11 grams per deciliter, and many women present with severe anemia, that is hemoglobin level less than 7 grams per deciliter, and women who suffer severe blood loss during childbirth continue to remain anemic further, and that can affect the growth of the infant, because that infant primarily had nourishment from the mother. So major causes could be nutritional anemia because of protein deficiency, or iron deficiency is a major reason, or there could be deficiency of vitamin B12 or folic acid. And as I said, hemorrhagic reason could be because of antepartum hemorrhage and more importantly the postpartum hemorrhage. And in some women there could be a hemolytic disease like sickle cell anemia or some other cause. Again, the major morbidity what we have seen among pregnant women is gestational diabetes mellitus. Postpartumly, once they are observed around 6 to 12 weeks, 2 to 16% of women with gestational diabetes mellitus were diagnosed with diabetes mellitus. If a woman who is non-diabetic at the time of conception becomes diabetic later on during the pregnancy, many among them continue to remain as diabetics, and more than one third of them have impaired blood glucose levels. And it has been observed that women who had prior gestational diabetes mellitus have 36 to 70% risk of developing type 2 diabetes mellitus later in their life, depending on other risk factors and length of follow-up. So it's very important to take care of gestational diabetes mellitus during the pregnancy and to follow such women once they deliver so that they don't move to type 2 diabetes mellitus later on. Same way, we have postpartum depression is quite common, and these women develop mood swings and other issues related to baby blues. Many women develop postpartum depression, even they don't want to feed their babies, they want to stay aloof. So it's a major issue arising nowadays among pregnant women. Some of them may land into frank psychosis, and in women who have some neonatal loss, they may present with PTSD. So mental health is very important in the postpartum period, and we need to prepare a woman during antenatal care about all these things. Some women develop stress in continence, and we need to address to these issues. Same way, some women may have obstetric fistula when we have a obstetric labor. So that is one of the sequelae of the obstetric labor, and we need to take care of that. We need to understand the outcome of obstetric labor with that. And some women may also develop pelvic organ prolapse. It could be either anterior vaginal wall, posterior vaginal wall, or apex of the vagina. And women who have uh, advanced age, more parity, and is obese, uh, and have obstetric labor have higher chances of these prolapses. There could be many non-medical risk factors for such maternal mortality and morbidity. Advancement of age, a woman with advanced age have higher risk of mortality, and young pregnant women, adolescent women also have higher risk, as we have discussed. More parity, more childbirths can have higher morbidity and mortality, or because of a short duration between two pregnancies, the woman doesn't replenish her stores, doesn't build up, so morbidity is more. Unintended pregnancies, she is not ready to have pregnancies, so they want to go for some abortion or some other termination later on, so that can add to the morbidity. Marital status, unmarried women are higher risk. Same way, if woman and her husband are educated, they are more accepting the antenatal care, try to have more of that care. Likewise, ethnicity and religion, we have some religious groups or some populations who don't uh, go for regular antenatal care and don't take care of their pregnant woman. Same way, poverty ridden population, they don't get adequate nutrition, they have successive pregnancies, childbirth and child care isn't optimal, and they have higher chances of maternal death and maternal morbidity. And same way, women who are obese, as I said, they have higher chances of getting PPH, diabetes mellitus, PIH, and women with bad obstetric history as has higher morbidity associated with pregnancy. Same way, we have social and economic factors like women's status, legality of reproductive health services, though under government schemes. We have services for adolescent women in reproductive age group. So we have national programs like RMNCH plus N. We have uh, other programs for pregnant women, lactating women like JSSK. So all these programs does help the uh, women in their reproductive age group, especially the adolescent women. But in situations where we have conflict, we have high risk of deprivation of services being provided to this woman. So during conflict, we need to address issues of maternal and child care. Same way, we need to address issues regarding services being provided by the health system with regard to the staff as per the public health standards, about the transportation of the woman, like uh, delivery preparation, where to move, when to move. So all these arrangements are to be taken care. We need to address the issues of water and sanitation, so lesser infections are there, and we need to address and be more accountable to MCH services. Let's move briefly to the childhood mortality and morbidity. What we have observed as per UNICEF, around in the population of around 25 years, 70% of deaths occur among 20 under 5 years of age. So among all uh, deaths which occur under 25 years of age, over 70% of death occur within first 5 years of life. And among those deaths within first 5 year of life, half of the deaths, around 47%, occur within the first month, that is neonatal period of the age. And we need to address better neonatal services to them. And again, 28% occur in the later part of the infancy, beyond neonatal period, and this much occurs because during the later part after post infancy period up to 5 years of age. And again, it has been found that 43% of adolescents suffer mortality. If we look beyond 5 years, among them, half of the deaths from uh, between 5 to 20 years, 24 years of age occur during the age of 10 to 19, that is the adolescent period. And the reasons could be varied from what we see usually in under 5 years. In this population, it could be because of accidents, because of addictions, because of injuries, because of mental health like suicide and other reasons. So this is we can see most of the neonatal deaths occur in the African region and part of the Asian countries. Same way, under 5 mortality we also see it occurs in these two regions more commonly, in some parts of the South America. If we look top 10 countries, again they are the countries which are in the African and Asian regions. Once we look at the cause of under 5 mortality, this is very important. So we divide, as we saw, that almost 47% uh, of all under 5 mortality occur during the first month of life, so what we call as neonatal death. And most commonly it could be preterm, which is related directly to the MCH services, the care of the mother. Then we can have intrapartum death because of loss, because of obstetric labor, because of PPH, because of other factors responsible for intranatal care. Then we have deaths related to sepsis or meningitis. We have deaths which could be congenital, and it can also be reduced. Then we have infections like pneumonia and diarrheal diseases, though not so common during this period. And we have factors like injuries and other factors, and some tetanus can occur, though it has been eliminated now. But once we look at the post neonatal period up to the 5 years of life, the reasons are mostly the infective in nature, like we have the pneumonias and the diarrhea are the two more common. Along with, we have the malaria, AIDS, meningitis, pertussis, measles. And if we look other causes, they could be in infective in nature. Some congenital anomalies can have survived beyond in neonatal period and they can present thereon. And we can have some intrapartum events that get postponed and can present later on, and some preterm cases also present with morbid mortality later on. So in the pre in the neonatal period, it's mostly the MCH services that are very important, so that can help us to reduce the intrapartum related factors. We need to take care of the preterm, so IUGR and other things need to be addressed. The preterm is if a woman is having successive pregnancies, all these factors need to be addressed. So this is how we classify them as what we have discussed. Uh, Again, we have discussed these major causes of mortality. There could be social developmental factors also because of mother's age, as we all have already discussed once we discuss about maternal mortality. Once we move to the country, presently we have 20 births per thousand population, and the mortality has again come down to 6.2. So we have 13.8 is the growth rate what's happening, and again the infant deaths per thousand livers have also come down. This is the latest figure being provided by the sample registration system. Uh, Again, if we look at the fertility of three major countries, most populous countries, India, United States, and China. In India, it has drastically, it has come down steadily over these years, and from initial 5.9, it has come down to 2.24 births per woman as on 2017, the latest data available. As we said, that birth rate has also come down over these years in a decadal decrease from 22.5, it has come down to 20, more among the urban population than in the rural population. Same way, the infant mortality has again come down from 50 to 32, a considerable decrease in infant mortality. But again, in the rural population, it's still higher than the national average. But urban health has taken care of infant mortality considerably. Lastly, moving to the childhood morbidity. The major causes of childhood morbidity are low birth weight, malnutrition, which could be mostly the undernutrition, but in nowadays, because of affluence, overnutrition is a problem again. Along with undernutrition, we have micronutrient deficiency, we have childhood infections that affect, and we have the disabilities and deformities. Let's go through them briefly. So, low birth weight is a child who is less than 2.5 kgs at birth, and it has two types. The preterm, if a child is born before 37 weeks of gestation, so obviously hasn't grown up fully to be a term child. But we have term child who have intrauterine growth retardation, and those children we label as IUGR. It's mostly the factors are maternal in nature. These children are at high risk of maternal neonatal morbidity and mortality. They have the impairment of congenital and psychosocial development, and they are at higher risk of developing chronic disease in later part of life, as we saw among pregnant women having similar features with hypertension and diabetes. So causes are mostly the maternal malnutrition, the micronutrient deficiency, especially anemia. Are mostly maternal health related short birth intervals. So the stores within the mother are not replenished on time, so they get less nutrition. So they have short birth. Because of short birth interval, they get low birth weight. Multiple pregnancies can cause that. Adolescent pregnancies and advanced maternal age group we have already discussed. Underlying medical conditions like hypertension, asthma, cardiovascular diseases, consumption of alcohol and tobacco, it causes vasoconstriction, so less of blood reaches the placenta, and subsequently less nutrition reaches the growing fetus. Then we can have non-obstetric reasons, as we discussed, like maternal infections, which include urinary tract infections, malaria, HIV/AIDS, STDs, and we can have mental health issues like depression that can cause that can affect the growth of a child and lead to low birth weight. Undernutrition, as we discussed, it contributes to nearly half of the under 5 deaths, and higher deaths from AR, acute respiratory infections, and epidural diseases because of undernutrition. they are at higher risk from dying these two diseases, which takes maximum toll. Then these children are at have increased vulnerable to disease. They have decreased growth, impaired mental development. Physically and socially, they are less productive for the country also. So once we look at the undernutrition, we have two indicators. Uh, one is which are age dependent, and we have age independent. So in the age dependent, if a child doesn't have the height for that particular age group, it's mostly because of chronic malnutrition. We call it stunting. If a child has lesser weight for that particular age group, and we label them as underweight. But if for that particular height, if a child has not gained that high weight, it could be because of acute conditions, and it's mostly because of acute malnutrition. That time we label it as wasting. We can see in this picture. So a normal child having a normal weight and height. If a person has lesser weight, you can see looking lean, and but height is same, so it's because of acute conditions, as we saw previously. Acute conditions, acute malnutrition. Child can have normal height, so we call it as wasting. A child has chronic mal nourishment, cannot hasn't achieved the height what is expected. That time we label them as stunting. And if child has both features of both of them, so that time we label the child as underweight. Again, we have seen previously ARI and diarrheal disease constitute the maximum number of deaths among the young children, along with malaria and vaccine preventable diseases like pertussis, measles. And then, lastly, we can have mortality and morbidity because of congenital birth defects. It could be because of maternal age. We have seen in the literature that a woman with age of more than 35 years is high risk of getting Down syndrome child. Again, maternal malnutrition, medical conditions like anemia, diabetes can cause birth defects. A diabetic mother can have a big child, and environmental factors can also cause birth defects, especially teratogens, environmental agents, drugs. If she is taking tobacco and alcohol consumption, can cause birth defects. Radiation has been found. Again, the pesticide use can all these lead to congenital birth defects. Some infections have been found to cause congenital defects like rubella. It causes CBS, CRS, congenital rubella syndrome, which affects the vision, hearing, and the heart anatomy. Same way, toxoplasmosis, STDs can cause, Zika virus disease can cause microcephaly, and sometimes the parents carry along genes that can cause birth defects, and like in thalassemia, sickle cell anemia, and some metabolic glycogen storage diseases. And last slide for our presentation is that some children present with disabilities, and that could be having impairment, which could be visual in nature, hearing problems, locomotor. So we need to address them with the rehabilitation of these cases. Then we can have children with cerebral palsy that can again need rehabilitation, along with mental retarded cases. And we have some children who have learning disabilities. They are normal looking children. They attend the classes regularly with regular students, but they have issues with regarding to difficulties with regarding to reading, and that time we call it dyslexia. And children who have dysgraphia, they have problems in writing. And that if a child is not able to calculate or do a simple mathematics, that time we label the child as having dyscalculia. And some children are very volatile. They don't stay at a particular place. They are very active, and that condition is called as attention deficit and hyperactive disorders. So this is the gist of the maternal and child health, the mortality and morbidity, and with successive presentations which are being uploaded on YouTube on the channel of Community Medicine GMC Srinagar, our students will be able to go through those presentations along with on-site offline classrooms. And we are here to help you, and we welcome your feedbacks also. Thank you very much.